There we go. So back up. Appreciate the invitation from Cheyenne and the Society to present on a recently recognized entity that may actually turn out to intersect with a lot of what's going on in the fat disorders and an awful lot of other problems too, as it's turning out. Got an awful lot to get through in the next interval here, so let's just get to it. The objectives, review the basic concepts regarding the mast cell activation disorders. We'll spend most of our time on the new kid on the mast cell activation disease block, in the last few years, mast cell activation syndrome. Talk just briefly about the general approach to diagnosis and treatment. That's a whole other lecture in itself. I have no conflicts of interest to disclose, and just be aware nothing is FDA approved yet for MCAS. It's all expert opinion on how to treat. We'll talk briefly about what we've long known about the mast cell activation disorders, very prevalent allergy and the very rare mastocytosis, and then spend most of the talk on MCAS and very briefly at the end some research issues. I want to start by illustrating one of the principal challenges to the clinician in coming to recognize what's turning out to be a very prevalent disorder, and that is the extreme heterogeneity with which the variability with which this clinically presents. In different patients, it can actually present give polar opposite presentations in various systems and parameters in the body. And to illustrate, I'll briefly present my very first patient in whom I came to recognize a mast cell activation syndrome. And just FYI, I was not the one who first recognized this. It was already in the literature for about a year before I kind of independently recognized my own first case. But the first case came to me allegedly with the diagnosis of polycythemia vera, a relatively rare cancer of the blood in which you have gross overproliferation of the red blood cells. And the very next patient in whom I came to recognize that there also was an underlying mast cell activation syndrome had exactly the opposite problem, where her bone marrow had completely given up making red blood cells. But just to further illustrate the heterogeneity of this, I'll briefly present a third case, off in a totally perpendicular direction. A lady who came to me with something I didn't even know at the time existed. Turns out it had been in the literature since the 50s, something called burning mouth syndrome. So let's get into these cases and then more into the generalities of MCAS. So the lady with P. vera had been fairly healthy for her first 20, 30 years, but then started developing a migratory rash, various constitutional issues over time, occasionally went to the doctor, pretty stoic, independent small businesswoman, didn't go to the doctor too much, but the evaluations she did pursue were all negative. Finally, the fatigue got enough where she went again to the internist. He checked, of course, a blood count, a CBC, expecting to find anemia. And to his surprise, her hemoglobin was actually a little bit elevated. So off to the hematologist she goes. And he did what at the time was actually a kind of insufficient workup for polycythemia vera or PV, and got a few hints of that and kind of prematurely diagnosed it and started giving standard treatment for that disease, which is to take blood out. Because these patients have too much blood in them, so he started taking blood out and to get the hemoglobin hematocrit down to normal. You'd like to think if you give the right treatment for the right diagnosis, the patient's going to get better. Well, she just kept getting worse in a myriad different fashions, as you can see here. Finally had to close her business and kept begging for a second opinion, and she kept getting, he said, no, I've got the right diagnosis, and in fact, he doubled down on the intensity of the therapeutic phlebotomy, and finally she self-referred, and she was 60 seconds into my clinic, and I realized, I'm a hematologist, I know P. vera, and there's no way she had P. vera. Her disease just didn't behave like P. vera behaved, so the question then became, what do you have that can not only drive up the hemoglobin and hematocrit, but also cause all of these other issues you've got? And I actually wondered, among a myriad of other considerations, I wondered right there at the first visit whether she might have mastocytosis, but I did the testing that I've been taught in my training to do to look for this rare disease, and she did not have an elevated tryptase. Her bone marrow was clean. I even biopsied one of these rashes, and it didn't really show much. But over the months I was evaluating her, it just kept smelling like mastocytosis more than any other disease, and I kept reading more about the biology of these cells that no doctors are taught in the 1 minute of teaching about mast cell biology and disease that they get out of their 10 years of training. And I began learning more ways to detect mast cell disease, finally stumbled across this marker called prostaglandin D2, and boy, is that a tough one to accurately measure. I made every mistake in the book about how to accurately measure this, but finally, after fixing all the mistakes, sure enough, there it was, an elevated marker. And so you got to have mastocytosis. Well, where is it? And so it's not in the bone marrow. It's not in the skin in this patient. So more reading. I said maybe it's in your GI tract. Sent her off to the gastroenterologist. And the biopsies from the upper and lower scopings on routine evaluation were completely normal. And I said that's not good enough. You have to go on and do the special staining, the CD117 staining, that reveals the mast cells in the tissue, because without that staining, the mast cells very reliably masquerade as other types of cells that you commonly see in those tissues. So this is what the routine staining looked like, and this is normal. But with the CD117 staining, it was instantly obvious. She had about 70 to 80 mast cells per high power field. This is nowhere close to what mastocytosis should look like, but it was clearly abnormal. So I called her in and I said, I don't know what else to call this other than atypical, grossly atypical mastocytosis. And there was really nothing in the literature about how to treat it, except that in the prior couple of years we had begun learning there was this wonder drug for chronic myelogenous leukemia, CML, that had just come out a few years earlier. And a couple of years after imatinib or Gleevec came out for CML, some clever people figured out that even though that drug never worked for most cases of mastocytosis, there were a few unusual cases of mastocytosis where this drug in very low doses worked wonderfully well. So given that she had atypical mastocytosis, said, let's try it. Said, try it at the lowest available dose for a week, and if you're tolerating it okay but unimproved, double it and then come back in a month and we'll go from there. And she came back in a month. I walked in the room almost at a double take when I walked in and saw what she looked like. She told me the first week, no response, so she doubled it. She woke on the morning of the 5th day. And this is significant, I think, because doctors are taught that it takes 4 days at a given dose to get to steady state. She woke on the morning of the 5th dose, hadn't even moved yet, just woke lying there in bed and was instantly aware that all of the symptoms she had been having for many years by that point were completely gone. And she leaped out of bed instead of taking 2 hours to crawl out of bed that she had been taking for the last several years, and basically put her whole life back together. That response has been sustained for about a dozen years now, and put her life and her business back together again. Now, literally the next day, I saw this patient for an initial evaluation. I was actually her 6th hematologic consultant. She had already seen a couple of academics, 3 other community folks who had all certified her bone marrow had given up making red blood cells. She had pure red cell aplasia. It actually was clearly not being driven by the usual known causes for that disease, for the most part, various viruses. She was heavily transfusion dependent, and even at that was only maintaining a hemoglobin in about the 5 to 6 range. And when I saw her, I said, look, there's no way this is PRCA. I know your bone marrow is giving up making red blood cells, but when you have that disease, the only symptoms you have are the symptoms of the severe anemia. And she had 597 other symptoms in every system across her body. PRCA doesn't do that. So what else is going on? And of course, with all the evaluations she had, everything else had been ruled out. But with the reading I've been doing on mast cell disease in the context of the first patient, I began wondering if this patient might have just a different variant of the same root issue. And so I did the testing, and bingo, there it was. Instead of calling her atypical mastocytosis, there was a new term just coming into the literature at the time, mast cell activation syndrome, or MCAS. And so I actually tried her first on antihistamines and got her hemoglobin from 5 up to 8 with no transfusions. So that was nice, but 8 is a far cry from the normal of 13, 14. So I tried other drugs. They didn't help. Finally, tried the very expensive imatinib, and in about a month and a half, boom, normalized her hemoglobin. Lost that response about a year later, went on and tried another drug called cromolyn, and once again achieved remission in just a month. At the time I was seeing those patients, I had been seeing another patient already for about 4 years. She had acutely in her early 50s suddenly developed this constant burning pain throughout the whole GI tract, far worse in the mouth, 11 out of 10 pain every waking moment of every day. How in the world she didn't commit suicide, I have no idea. But extensive evaluations over a year after the pain emerged found nothing. Finally, an enterprising endocrinologist said, maybe we're dealing with a wacky kind of neuroendocrine tumor. So he checked a chromogranin A level, which is often a marker for those tumors, and it was 100-fold elevated. So, you must have a neuroendocrine cancer. Off to oncology you go. I was the dumping ground for the mystery cases in my academic oncology division. So she comes into my clinic, I go in the exam room, and again, in 60 seconds, no, you don't have a neuroendocrine tumor, because there was no question she was in a lot of pain, but she didn't look anything like you'd expect somebody to look if they have the sort of advanced cancer that you got to have to explain 100-fold elevated chromogranin levels. So what else can cause a 100-fold elevated chromogranin level and all these other problems she had? And I didn't know. I had never been taught any of that. The only thing I was taught that causes a 100-fold elevated chromogranin level is a neuroendocrine cancer. So I did every test to look for a neuroendocrine cancer and didn't find anything. And I talked to all the other neuroendocrine cancer experts in the country, and they said, no, it's got to be a neuroendocrine cancer. We don't know why the tests are negative. Just keep repeating the tests. This is $50,000 worth of tests. Just keep repeating them every 6 months. It'll show up. And I said, that didn't make any sense. So you don't want to know all the other diseases I considered in the next few years, but around the time I was figuring out the first 2 MCAS patients, I began wondering, could this lady just be another variant? And so I ran the blood and urine testing. That was negative, but I went back to her old GI tract biopsies, and boom, with the special test of the CD117 staining, there it was. Antihistamines and NSAIDs overnight dropped the pain from 11 out of 10 to 1 out of 10. And I called up our chief oral surgeon, said, do you have any of these BMS patients? Oh, God, I got a ton of them. I hate seeing them. We can never find anything wrong in them, and nobody knows what to do with them. I said, I got an idea. Send me a few. And every single one I've seen since, they all have MCAS, different markers in different patients. Different markers of mast cell activation, but they've all got it, and they've all been responding to various mast cell targeted therapies. I apologize for taking all that time, but I think it's important to understand just how heterogeneously and how polar opposite this disease can present in different patients. Highly divergent presentations, but clearly the same root issue. How can one disease do this? Could other weird presentations be possible? I'm going to answer all those questions, but first, They say you got to understand your history so you don't make the same mistakes in the future. So let's take a brief moment to look at what we've known in the past about mast cell disorders. First, the very prevalent allergic disorders. About actually 10 to 20% of the world population now recognizes having one allergic disorder or another. We know the incidence and the prevalence has been increasing in the modern era. A lot of theories about that, no hard proof of anything yet. We know these disorders are conditioned by both genetic and environmental factors. And yes, there unfortunately are some folks with the allergic disorders who die from like anaphylaxis each year, but for the most part, there's relatively little mortality, but a lot of quality of life issues. And given that these patients typically live a normal lifespan, this is important. And it's a huge segment of the world population. Now, contrast that with the very rare mastocytosis. And it's the rarity of this, which is why doctors only get 1 minute of teaching about this in 10 years of training. I mean, most doctors go out in a practice for 30, 40 years. They'll never see a case of mastocytosis. So why would you spend more than 1 minute in training teaching the students about this? So this actually dates back to the 1860s when the first form of mastocytosis was recognized in the skin, the most common skin form of this, called urticaria pigmentosa. It was a whole decade later before the mast cell itself was discovered. And then another decade before the two were linked, another half century before we began realizing mast cells could cause not just skin disease, but internal disease. And actually, that's about when we first started realizing all these different so-called mediators that the mast cell produces and then releases. Over time, we began developing classification systems for the disease. In the mid-90s, a couple of Japanese groups identified there was this one particular mutation in codon 816 of the mast cell regulatory molecule called KIT. And that mutation was found in almost all cases of mastocytosis, and a Spanish group a few years later identified a unique flow cytometric signature for mastocytosis patients. And 2001 was when the World Health Organization's classification system for mastocytosis came out, and we've been using that ever since. And coincidentally, that year was also the year that the wonder drug for CML, imatinib, first came out. And basically in the last 20 years, we've been coming to understand that in contrast to most cancers, and mastocytosis is a cancer of the mast cell, fortunately a very slowly growing cancer in most mastocytosis patients, but we've been coming to understand that actually in mastocytosis patients, the overgrowth of the mast cells is not causing them any problems. It's the inappropriate activation of these malignant mast cells, the inappropriate production and release of all these mediators from the mast cell. That's what's causing the symptoms in these patients. So this is the landscape of mast cell disease we long knew about, sort of a mountain of mast cells. This is not drawn to scale, but you get the idea that the bulk of the mountain are the allergic disorders, and the tiniest tip of the mountain is mastocytosis in its assorted forms, with the cutaneous mastocytosis much more commonly found in childhood, outnumbering systemic mastocytosis, usually found in middle to older adulthood, by about 10 to 1. Now, the whole mountain features inappropriate mast cell activation, but only the tip of the mountain, mastocytosis, additionally features grossly inappropriate, cancerous levels of mast cell proliferation. So that's the spectrum of mast cell disease we used to know about. So now let's walk into the realm of mast cell activation disease. Actually, back in the 80s is when we saw the first publications hypothesizing that, if we've got this disease called mastocytosis, where there's an inappropriate overgrowth of the mast cells, cancerous overgrowth of the mast cells, and inappropriate activation. There ought to be diseases of just inappropriate activation with little to no proliferation. But nobody really knew how to recognize that at the time, but it was a thought. And fast forward a quarter century, and we finally get around 2007 the first case reports of published in the literature of what is now called mast cell activation syndrome. And that same year is when we saw the first studies coming out of the University of Bonn showing that just about every single one of these MCAS patients actually also have mutations in KIT, but almost never that codon 816 mutation that you find in mastocytosis. And instead, it's this huge menagerie of other mutations that you find scattered all throughout the rest of KIT in the MCAS patients. And then starting the next year, we began finding that, oh boy, there are a lot of mutations in regulatory genes in the mast cells other than KIT that are mutated in most mastocytosis patients, and we then later began finding the same thing in MCAS patients. 2010, we had a nice confirmatory study. Again, this was also out of Bonn, but again showing that almost every MCAS patient has lots of mutations in KIT, and few to no, usually no mutations in KIT in healthy controls. So really starting to look like it's these mutations just in the mast cells. These are not, for the most part, these are not inborn or germline mutations. These are acquired mutations. Kind of similar to cancer. That's what's happening in cancer. It's acquired mutations that drive cancerous overgrowth of various cells. But these acquired mutations aren't really driving cancer of the mast cell. They're driving inappropriate activation of the mast cell. So in 2010, that's also the year that we had out of Harvard and Vienna NIH the first proposal. We ought to rename this area of disease from mastocytosis to mast cell activation disorders on the new understanding that first and foremost, what's going on in all patients with any form of mast cell disease is inappropriate activation. And then there's this tiny subset of mast cell activation disorder patients who also have a grossly cancerous extent of mast cell proliferation. So so MCAD is kind of this umbrella term that emerged at that point. And that paper also included the first proposal for specific diagnostic criteria for mast cell activation syndrome. But there are a lot of problems with that proposal. So there was another paper came out a few months later, and full disclosure, I was one of the partners in crime on that paper, offering an alternative proposal for diagnostic criteria that we thought were more sensible. The original proposal was revised the next year, but it was still problematic. It actually was technically updated again in 2019, but really pretty much the same as it was in 2012, still quite problematic. The WHO revised its diagnostic criteria for mastocytosis in 2016, but they recognized the ongoing controversy between these two different camps of thought about how to diagnose MCAS, and they said, we're staying out of it for right now. So the latest WHO statements on mastocytosis say nothing about MCAS, and that was probably smart. The alternative criteria were updated again in 2020, and that's the point at which we began referring to the original diagnostic criteria as consensus 1 diagnostic criteria, and the other school of thought offers the consensus 2 proposal. So this is the new understanding of the so-called landscape of mast cell disease. The mountain that we recognized before actually is just the tip of an iceberg. of mast cell disease, and submerged below this waterline of relatively easy clinical recognizability is this huge array of disorders, very heterogeneous collection of disorders that we really haven't learned to subset and subtype, and we're just calling the whole bulk, submerged bulk of this iceberg, we're just calling it MCAS at this point. I don't doubt that over time we'll get better at teasing all the different variants apart, but for right now it is all called MCAS. So the whole iceberg features chronic inappropriate activation of the mast cells. It's just the tip of the iceberg that additionally features the cancer of the mast cell, the cancerous overgrowth that leads to a diagnosis of mastocytosis in one form or another. So we now have all these different mast cell disorders under this umbrella term of MCAD, and these disorders range from extremely rare, as you find with mast cell leukemia, probably about 1 in 10 million for that, to we don't have very much well-done epidemiologic research in MCAS yet, but the preliminary published research is suggesting MCAS is a really prevalent disorder, roughly about 17 to 20% of the general first world population. And this is just a polar opposite from what we always thought about mastocytosis. Mastocytosis is as rare a disease as it was always thought to be. It's just that MCAS is incredibly common. So a little bit more about normal mast cell biology. These cells, they're part of the blood cell system. They're born in the bone marrow, so to speak. Very few of them in the body relative to the numbers we have of other types of cells. After being born, so to speak, in the bone marrow, they leave the bone marrow pretty quickly. They only spend a little bit of time in circulation, very quickly exit into various peripheral tissues all over the body where they complete their maturation. Pretty sparsely distributed in most tissues in the body. Where they're dominantly positioned is at the environmental interfaces and in the walls and sheaths of all vessels and neurons. And this is all these different sites, the environmental interfaces and the vessels and the neurons. This is where you kind of expect them to be positioned to serve their principal role in human biology as the sentinels, alerting the body to any assaults or insults upon the body. That's their principal role. Lymphocytes take hours to activate when the body is being attacked. Neutrophils take minutes to activate. The mast cell, as I'll show you shortly, activates in sub-second time. So the principal function of the mast cell is to synthesize and release various active substances we generically call mediators. Different subsets of mediators are being released in response to different types of triggerings of the mast cells. And you also need to understand that normal numbers of normally functioning, that is unmutated KIT, these KIT molecules sitting on the surface of it's a transmembrane tyrosine kinase receptor. KIT is expressed on the surface of the mast cell tenfold more brightly than on any other cell in the human body. And you got to have normal numbers of normally functioning KIT on the surface of the mast cell to accomplish critical mast cell functions like survival of the mast cell and activation of the mast cell. This is a grossly oversimplified schematic about how the biology of all this is working. Basically, you have a homodimer of KIT at the surface of the mast cell, and when the natural ligand of stem cell factor binds with that homodimer, you get instant conformational change of the intracellular portion of the transmembrane tyrosine kinase that is KIT. And with that conformational change of the intracellular portion of KIT, you then get immediate activation of a wide range of downstream pathways, including a number of the pathways that Dr. Herbst mentioned she was wondering might be relevant in Derkham's disease and some of the other lipid disorders. So just one aspect by which our two diseases might come to intersect. So, oh wow, that did not. So there are many, every physician in their 1 minute of teaching about mast cell biology and disease, they get taught the classic way that mast cells get activated, where polyvalent antigen goes floating by and comes to engage with adjacent IgE antibody molecules that are specific for that antigen. And these IgE antibodies have been pre-bound to IgE receptors on the surface of the mast cell. So when an antigen comes by, it links with 2 or more adjacent IgE antibodies that are specific for that antigen, and that's how you just, boom, get instant activation of the mast cell. But it turns out there are an awful lot of other ways to activate the mast cell too. A whole variety of physical stimuli, physical forces, many other chemoreceptors, all the different types of histamine receptors. We talked about the stem cell factor receptor. Actually, the mast cell has receptors for all the different types of immunoglobulin, complement molecules, platelet activating factor. CRF is an interesting one. Corticotropin releasing factor is almost instantly released by various organs in the body, particularly the brain, anytime we're under stress. Physical or psychological stress, and stress has long been recognized to be a prompt, potent trigger of mast cell activation. The mast cell also has many receptors for a variety of other neuropeptides, pain transmitters like substance P. It has receptors for the opioids, paralytics, the benzodiazepines, the cannabinoids, and so on and so forth. And of course, the toll-like receptors, this is what dominantly confers upon the mast cell its ability to recognize various infections. Again, the principal role of the mast cell in the body is to be the sentinel, alerting the rest of the body to invasion, to assault, to insult, which often happens via infection. And that also links to your thought about infection triggering escalations of Derkham's disease, and I'll get to a little more on that in just a moment. So, courtesy of Dr. Theo Harides at Tufts University, a video 3D microscopy of what happens when a mast cell gets exposed to one molecule of substance P, a pain transmitter. And boy, that didn't work. And because I don't have my laptop up here, I don't have a way to activate that. But if I could, you would see that mast cell just erupt with outpocketings, just almost explosively degranulate, releasing all of its mediators into the interstitium around the cell. Sorry, I can't show that to you. So the mast cell is capable of synthesizing and releasing, actually, listen, we're taught in our training the mast cell produces maybe a couple of mediators, histamine and tryptase, that's it. No. The biologists have been figuring out for the last 40, 50 years that the mast cell actually produces more than 1,000 mediators. And this list here, that's too small a font for you to read, but that's kind of the whole point, because this list of mediators on this slide is only a tiny subset of all of the mediators the mast cell actually puts out. So these are the current diagnostic criteria for systemic mastocytosis, and I'm not going to go into the details. Suffice to say, these criteria do a great job there's some problems here, but overall they do a pretty good job in very specifically identifying patients who have mastocytosis, but they also create a problem in that it turns out there are an awful lot of patients who have the symptoms that we're taught come along with mastocytosis, and yet when you go doing the testing for mastocytosis, you can't find it. And based on all these different symptoms, they wind up getting into the hands of lots of different doctors. They get lots of different diagnoses from doctors looking at the different symptoms from different angles. But you never get a satisfying, unifying answer for all their problems. So what do you do when it kind of behaves like mast cell disease, but it isn't the allergic diseases or the mastocytosis that are the only mast cell diseases you were taught about in your training? What do you do when it looks like a duck, acts like a duck, quacks like a duck, but it's not a duck? So this is a situation where it now becomes reason. I'm not saying that every chronically, mysteriously ill patient has MCAS at the root of it. What I'm saying is these are the patients where, especially if they fit the pattern that I'll show you in just a minute, the overall themes of the disease, these are the patients where it starts to become reasonable to at least consider whether they might have MCAS at the root of their issues. These were the original, the so-called consensus one diagnostic criteria for MCAS, and I don't have the time to go into the details. Suffice to say, you can see there are a lot of problems here, and happy to talk about it later if anybody wants to. These are the consensus 2 criteria. The overall structure here is very similar to how the WHO structured its criteria for systemic mastocytosis, and basically to make the diagnosis, you put together a combination of the one major criterion, the chronic symptoms of inappropriate mast cell activation, together with one or more of the minor criteria, and the one that that's found in most patients, kind of obviously, are laboratory evidence of mast cell activation. So there's increasing estimates of prevalence. Back in the early part of this century, again, we thought maybe this might be as rare as mastocytosis, but in pretty short order, we began realizing, no, this is way more prevalent. And there's and researchers looking into all these other chronic multi-system inflammatory diseases you see listed here have begun realizing in the last 20 years or so that actually mast cell activation is critically involved in the development of all these disorders, and it sort of raises the question as to what proportions of the populations of patients bearing each of these diagnoses might actually have one variant or another, one mutational variant or another of MCAS at the root of these diseases. So a lot of research to be done, but I got to keep moving. So again, the preliminary research, most of it out of the University of Bonn, is showing that this is clonal. In other words, mutationally rooted, but again, not inborn, not germline mutations for the most part, but for the most part acquired, or what we call somatic mutations. And in just KIT alone, more than 50 such mutations have been found. In fact, we now know that most MCAS patients actually have multiple mutations in KIT. The problem is, from a clinical perspective, that the only KIT mutation we can presently test for in the clinical laboratories is that codon 816 mutation that's found in almost every case of the rare disease of mastocytosis and is almost never found in MCAS. And my bet is it's probably going to be about 10 to 20 years before the specialized genetic testing that can be presently done in a few research laboratories around the world to find these acquired mutations that are just in the mast cells, be about 10 or 20 years before that specialized genetic testing migrates to the clinical genetic laboratories. And hopefully at that point the testing for this disease will get a lot easier. So just trying to illustrate to you here just how many different mutations have been found so far in KIT, in just KIT in MCAS patients, let alone all the other mast cell regulatory genes. So to answer the question, are other presentations of MCAS possible? I mean, do the math. Mast cells produce and release actually not scores, but hundreds of mediators. We know that any one activating KIT mutation is going to drive abnormal release of some number of these 1,000+ mediators, and that creates some potential for multi-system illness and heterogeneity from one patient to the next. But wait, it's more complicated than that, because we know it's not just one mutation in most of these patients. Most of these patients have multiple mutations in KIT. That increases potential for multi-system illness and heterogeneity. But wait, it's more complicated than that, because we know it's not just KIT that's mutated. We know most of these patients have multiple mast cell regulatory genes mutated. But wait, it's more complicated than that, because we know each mediator has not just one effect. Each mediator has its own unique, huge array of effects throughout the body. Direct effects, indirect effects, local effects, remote effects, acute and delayed and chronic effects. So this is how one disease, so to speak, is capable of causing so many different problems. So if it is so mutationally heterogeneous and so heterogeneous in its abnormal expression of all these different mediators, is it even possible to give an overarching description of what it looks like clinically? And I struggle with this for several years. But this is the best description I've been able to come up with so far. It's a and I'll be the first to acknowledge how nebulous a description it is, but it is what it is. It's a consequence of the effects of the mediators. So many of the mediators are, they have effects that we would recognize as, or that we label as inflammatory. So chronic multi-system inflammation is the universal constant. All mast cell patients have chronic multi-system inflammation. May not be severe, may just be mild, and it may be a very different pattern of inflammation from one patient to the next, but it is the universal constant with this disease. Then there's a plus minus of allergic type phenomena. I say plus minus because there are plenty of mast cell patients who do not have a speck of allergy to them. And then at the opposite end of that spectrum, if you can even imagine such misery, there are those relatively few mast cell patients who are literally in 24/7 anaphylaxis. And then everybody else on the allergy spectrum in MCAS is somewhere in between those polar opposite ends of the allergy spectrum. And then there's one other plus minus theme here, and this is the hardest of all to clinically recognize. Listen, the symptoms of inflammation and allergy, they emerge acutely. Our mammalian brains are wired to recognize acute issues pretty well, but boy, are we miserable at recognizing the slow emergence of problems. But it is that's what's going on in this third area, where you have abnormalities in growth and development, what we would medically call dystrophisms, in potentially any tissues, any organs, any systems in the body. Thankfully, much more commonly benign than malignant. But as slowly as these abnormal growth issues emerge, you can understand it can be difficult sometimes to recognize them. So, what does it look like in the clinic? Well, these patients usually don't present until they've been sick for decades. They've been going to doctors forever, but nobody can ever give them an answer. If you take a careful enough history, the kind of history you learn to take when you were in medical school, you can actually trace at least some of the symptoms of these patients. Almost in almost every MCAS patient, you can trace at least some of the symptoms back to at least adolescence, sometimes even back to childhood or even infancy. And the pattern over time, it's always waxing and waning to some degree, but it tends to wax and wane about a pretty stable baseline for long periods of time. But then from time to time through a mast cell patient's life, the the disease can fairly suddenly, significantly escalate, and the baseline level of misbehavior of the dysfunctional mast cells, and these escalations tend to shortly follow, by anywhere from a few days to at most a few months, shortly follow major stressors, either major physical stressors like infections or traumas like surgeries, or even major psychological or emotional stressors. And we think what's happening at those events is that the cytokine storms that are coming into the body in concert with those stressors, these cytokine storms are actually what's inducing the development of additional somatic mutations in the mast cells to make the mast cells misbehave even more egregiously, and we're still trying to figure out exactly why these cytokine storms would actually induce those additional mutations. So it's almost always multi-system, a perplexingly, again, waxing and waning course. Externally, they often look fine, but you ask them how they feel, and pardon my French, they'll tell you they feel like shit. We used to think tryptase was a good marker of mast cell activation. We now realize really all that it marks well for is how many mast cells you have in the body. So if you got a cancer of the mast cell, you pretty reliably have a significantly elevated tryptase level. But if your problem with the mast cell is inappropriate activation with little to no proliferation, then the tryptase level is going to be elevated little to none, usually none. And instead, in MCAS, you have to look at a variety of other mediators. You can't go testing all 1,000 of them. Most of them are not particularly specific to the mast cell. So there's about 10 or so that are relatively specific to the mast cell, and that's what we test. But it is challenging to test for these, and I don't have time to go into those details. These patients see boatloads of doctors, acquire truckloads of diagnoses, try plane loads of treatments, often to little to no avail. And so put yourself in their shoes. You've seen all these doctors, all this testing that got you nowhere, all these treatments got you. Shut up. Because it gets you, all your complaining gets you nowhere except maybe draining your bank account and getting all those around you, the doctors, your family, your friends, thinking you're crazy. And so they shut up. So a doctor coming to see one of these patients needs to extract the symptoms, the history out of these patients, because these patients learned a long time ago, I really should not go talking about this, that, or the other symptom with any more of my doctors for the rest of my life. So it is challenge. It takes time. So system by system, the constitutional issues are all over the map. These are the patients who have the weird and prolific allergies and intolerances that never made any sense to you before. I promise you, the patient is not allergic to levothyroxine or acetaminophen. It's rather the excipients, the fillers, the binders, the dyes, the preservatives in these medication products. That's what's triggering their dysfunctional mast cells. Look at the theme here as we go system by system. It's inflammation, 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 different fashions in different systems. This is the universal theme, system by system. The cardiovascular issues are all over the map, including some really weird phenomena like Kuhn syndrome and Takotsubo. These patients have their blood pressures and pulses bouncing all over the place. Often these episodes of tachycardic palpitations erupt out of nowhere. Again, inflammation. They drive their gastroenterologist crazy with the alternating diarrhea and constipation. These are the women who have UTI after UTI after UTI, and yet when you do the urinalyses, you can't find the infection because they don't have infection. They've got inflammation that makes it feel like they have the inflammation that an infection will cause, but they don't have the infection. This is what the urologists have long been calling interstitial cystitis, and in more recent times, a few urologists are beginning to understand that it's really MCAS that's at the root of most cases of IC. The bones, the muscles, the joints are often involved with this. And remember, we said where are the mast cells dominantly hiding out? At the environmental interfaces. So, of course, the skin and all the rest of the integument is involved with this disease. The central and peripheral nervous systems, and whenever you get the central nervous system going awry, you're going to have symptoms that might be, certain symptoms might be labeled as neurologic symptoms. Other symptoms might be labeled as cognitive symptoms. Many of these patients describe massive amounts of brain fog. But also some symptoms might be described as, quote, psychiatric symptoms. Many of these patients come to be thought to have primary psychiatric disorders, anxiety, panic, whatever. No, it's secondary to the mast cell disease. There may be a little bit of reactive anxiety in there because you're so used to being gaslit by all the doctors that you see, but it's dominantly primary mast cell disease, where the mediator release is driving the neurons to malfunction and give you that sense of all sorts of anxiety disorders and mood disorders, even psychoses occasionally. The hematologic issues, as I illustrated at the beginning of the talk, are all over the map. The marrow is actually usually normal. I marrowed my first 100 MCAS patients. I couldn't find anything significant in any of them. I gave it up. If I see a patient whose history kind of aligns well with what I expect mastocytosis to look like, fine, I'll do a marrow. But the vast majority of MCAS patients do not need a marrow exam. The immune system issues are all over the map. The endocrinologic and metabolic issues are all over the map. Growth and development issues are all over the map, including Derkham's disease, and let's talk about that. So far, and look, I obviously see a biased selection of patients, but for what it's worth, every Derkham's patient I've come to recognize in the last 14 years has had provable MCAS in them. That doesn't necessarily say that MCAS is what's at the root of Derkham's, but it sure is an interesting correlation or association. Furthermore, some improvement in the Derkham's disease, and sometimes massive improvement, is usually seen with an assortment of mast cell targeted treatments. And in my own, again, I've not seen many Derkham's patients. It's a rare disease, but I've seen some very nice improvement in Derkham's disease with low doses of imatinib. It always makes me a little uneasy when I go write the prescription for imatinib because it costs about $150,000 a year here in the U.S. For idiotic reasons, it's about $300 a year in most of the rest of the world. But here it's about $150,000 a year. But fortunately, the costs are beginning to drop significantly. I think now it actually is possible to get it for about $1,000 or $2,000 a year under special circumstances here in the U.S. It's rapidly evolving. So the aberrantly expressed mediator milieu, which drives a Derkham's phenotype, remains unclear, and we need studies to better understand the connections here. So, such a nebulous, heterogeneous disease, how do you diagnose it? We need to take a complete history and physical, and that takes time, and doctors in the room know that's the one thing we're not paid for. We're not paid for our time. We're paid for the number of patients we see and paid for the number of procedures we do. And we are not paid for time. But there's no getting around the time it takes with these patients. And of course, you got to restore your faith in Occam's razor. Honestly, these patients come to you and they've got 58 problems on their problem list, many of which are itis, inflammation, inflammation, inflammation. So what's more likely? That these patients are so unlucky as to have coincidentally acquired so many different problems, all of them developing independently of one another, or do they have one diagnosis that actually is biologically capable of accounting for everything here? So Still, just because you have one disease doesn't make it impossible to have another disease, so the astute diagnostician does need to keep an eye out for lots of other things whose symptoms can overlap with mast cell disease, including the autoinflammatory syndromes that we used to call the periodic fever syndromes. Got away from that because many of those diseases actually do not reliably manifest periodic fever. This is the diagnostic approach at present. It's too small for you to read, and I don't have the time to go into it. The bottom line, this is a whole nother lecture in itself. The bottom line is step one, at least come to suspect. Be aware of that the disease exists and be able to recognize the patients in whom it's reasonable to consider this diagnosis, and then do initial testing, and often that's as simple as just checking a tryptase level to make sure you don't need to go looking for the rare disease of mastocytosis. But most patients then wind up having to go to that bottom box of additional mast cell mediator testing, and that is challenging business. It's not that you can't do it, it's just you got to learn the nuances, the tips and tricks of doing it right. Very quickly, we think most of these patients are going to live a normal lifespan. So thank you. It obviously becomes important to recognize it, diagnose it, and treat it so that you can give them a better quality of life for the remainder of a normal lifespan. Treatment, I don't have time to go into details. Basically, it's largely as for indolent mastocytosis because the symptoms of indolent mastocytosis are not coming from too many mast cells. The symptoms are coming from the inappropriate activation. So identify and avoid the triggers, and then inhibit production of the mediators as best you can, and lots of drugs for doing that. And then try to inhibit release of the mediators. Some people call that mast cell stabilization. And there are lots of drugs available for looking at that. And try to block the effects of those mediators that do get released. This is not a cancer. You don't give chemotherapy for this. You're not going to kill the mast cells. In theory, bone marrow transplantation should be able to help with this, but the only patients you're going to do that on are the sickest of the sick. Those are the patients who are going to have the hardest time safely getting through as toxic a treatment as stem cell transplantation is, so nobody should be doing this outside the context of a carefully designed and monitored clinical trial, which is not going to happen anytime soon. And of course, if any of those mediators do escape from the mast cell and cause downstream issues, you got to deal with those downstream issues. There's some natural and complementary treatments that I don't have time to get into, some non-pharmacologic therapies that may help, and we're beginning to understand the biology that this works by. This is a listing, actually 2 slides worth, of all the other diseases, all the other comorbidities I've seen in my patients over time, where my experience has led me to suspect that one variant or another of MCAS might be at the root of some of these disorders. Lots of directions to go in for research. It's going to take armies of researchers, centuries to untangle all the biology of all this. But basically, we need to improve the diagnostic techniques. Hopefully, the genetic testing will be easier than the mediator testing. Better understand what's driving this, and then get better at predicting which treatments will help which patients. And of course, we need to better educate everybody. And I've got 5 seconds to go, and I am done.
We actually have time for a couple questions.
Sure.
Can I go up to the mic?
Sure.
Okay. And your mic's up, so you're good. Okay. What kind of doctor should be seen to determine a mast cell activation syndrome? And what should be included regarding assessment and testing?
I just realized I had my mask on the whole time. Might as well leave it on at this point. My apologies.
I'll keep my 6 feet.
Obviously the best answer is the glib answer of, see a doctor who's familiar with MCAS, but I estimate, 0.00001% of the world's 15 million or so physicians have even heard of this. let alone the even fewer who have developed good familiarity with this. So you can look around for doctors who have heard of this, have come to know it. You'll probably have a hard time finding them. Frankly, the better approach, and this disease intersects with every specialty, every system in the body, so every specialty. I have learned that any type of doctor is capable of diagnosing this and managing the treatment of this. It's much more an issue of whether the individual doctor, again, irrespective of specialty, whether they're willing to learn about something that they, based on their training, they can't even imagine initially how this could come to intersect with their specialty. Are they willing to learn? And are they willing to at least try to help the patient with this? The fact is, the vast majority of treatments for this disease are safe and easy for any doctor to prescribe and to manage. It's just that for the most part, they're treatments most doctors have never even heard about because they've never had to take care of mast cell disease before. But if they're willing to learn and willing to try, actually it's a very straightforward thing for the doctor. The patient comes in, you decide whether the thing they were trying last is helping enough to make it a keeper or it's not, and you dump it. And then you look at what the principal remaining symptoms are at that point. You decide which drug you want to try next, and you write the prescription. The patient goes away. It only takes a month. For the vast majority of these drugs that make sense to try for this disease, it only takes a month to figure out whether that drug is going to bring significant benefit for the particular variant of MCAS that particular patient has in his or her body. And so you come back in a month or two and you make a decision, it's a keeper or not, and you move on. And in that fashion over time, you piece together what usually in the end is a pretty small cocktail of mast cell targeted treatments, which collectively get to the patient to the goal of feeling significantly better than the pre-treatment baseline the majority of the time. You can't cure it. You can't make them perfect. You can't even control it well for 100% of the time. But you can, my experience has been the vast majority of these patients, you eventually find some cocktail that gets them significantly better the majority of the time. And given that they've been told for 20, 50, 70 years of their lives that, first of all, it's all in your head, and they've been told there's nothing we can do for you, I don't care how long they've been sick with this. Once you find the drugs that are the right molecular keys for fitting into the particular molecular lock that is the individual patient's particular variant of this disease, they come back in just a month, and you walk in the exam room and your head spins 360. You can't believe you're seeing the same patient.
Okay. Well, thank you so much, Dr. Afrin. We really appreciate your presentation.
Thank you.
Thank you.